All right, let's get into this. We've all been there, right? A bad stomach ache, maybe you can't keep anything down, you just feel off. But for a clinician, those very common complaints, they could be the first clue in a serious medical mystery. So how do they actually tell the difference between a simple bug and a surgical emergency that could be life-threatening? Well, that's the detective work we're going to break down.
So this is really the central question, isn't it? The moment you walk into an emergency room with one of these issues, a clock literally starts ticking. And the doctor's job is to figure out fast, if this is something that's going to get better on its own, or if they need to rush you into an operating room, like right now.
I mean, think about it. Difficulty swallowing, vomiting, constipation. These are, hands down, some of the most common reasons people go looking for medical help. They're everywhere. And you know what? Most of the time, the cause is totally harmless. But it's those rare exceptions that keep doctors on their toes, because hidden inside these very ordinary complaints can be the first signs of something incredibly serious. And this quote right here, it just sets the stage perfectly. Catastrophic intra-abdominal events. I mean, that's a pretty intense phrase, right? It's basically medical language for things like a ruptured organ, or the blood supply to your intestines getting cut off, or a total bowel blockage. The stakes are just unbelievably high, which is why this whole diagnostic process has to be so careful and so precise.
So where does this whole investigation kick off? You might think it's with some high-tech, fancy scan, right? Nope. It starts with a conversation. The single most powerful tool a doctor has, at first, is just listening. Because the tiny little details of what you're feeling, those are the first and, honestly, the most important clues they're going to get.
So let's take that first one, difficulty swallowing. The medical term is dysphagia. What's absolutely fascinating here is how a doctor can start cracking the case with just one simple question. It's not just that you have trouble swallowing, it's what you have trouble swallowing. That one little detail is like a fork in the road that sends the diagnosis in one of two very different directions. And this is why it's so clever. Think about it. If you can still get liquids down okay, but solid food gets stuck, that points to a physical blockage. Something is literally making the pipe narrower, maybe a tumor or scar tissue. But if you have trouble with both solids and liquids right from the start, that suggests the problem isn't a blockage, but an issue with the muscles and nerves themselves, a motility disorder where the esophagus just isn't squeezing properly. The patient's story tells the doctor exactly where to look next.
And it's the exact same kind of detective work with vomiting. Again, it's not that you're throwing up, it's what's in it. If you're vomiting up food that looks pretty much the way it did when you ate it hours ago, the blockage is probably high up, right at the exit of the stomach. But if the vomit is green or yellow, that's bile. And since bile is made in the small intestine, that tells the doctor the problem is much further down the assembly line. The color itself is a roadmap pointing to the location of the problem.
All right, so after the story's been told, what's next? Well, we move into the next phase, the hands-on investigation. This isn't just about randomly poking someone's belly, it's a really systematic search for physical clues that can either confirm or totally contradict the theories the doctor has been building from the patient's story. And this leads us to a procedure that, let's be honest, nobody loves, but according to our source material, it is absolutely 100% non-negotiable. It might be uncomfortable, but when you're dealing with severe constipation or a potential blockage, this exam can give critical information that no high-tech scan can provide, at least not as quickly. So you might be asking, why is it so vital? Well, look at what this one simple exam can find. It can immediately diagnose a major blockage from impacted stool, which is super common in older patients. It can help a doctor feel for low-lying tumors, find signs of hidden bleeding, and even check for issues with muscle function. It's just an incredibly valuable source of evidence. Okay, so the doctor has heard the story, they've done the physical exam, they've basically got a rough sketch of the suspect. Now it's time to bring in the technology. This is where the advanced toolkit comes out to actually look inside the body, confirm those suspicions, and get a really precise picture of what's going on.
And you can really see the methodical approach here, right? It's this logical escalation. Every step builds on the one before it, narrowing down all the possibilities and focusing the investigation. You don't just jump to a CT scan for every tummy ache. You follow the clues, from the story to the exam, and then you use the big guns to get a clear look at the target you've already identified. And here are some of those key tools in that toolkit. An endoscopy lets a doctor put a camera down and look directly at the esophagus. It's an absolute must for anyone over 45 with new swallowing problems. A CT scan is the workhorse. It's amazing at finding the exact transition point where a bowel is blocked.
And then you have other tests, like a barium study, which can show these classic, almost iconic signs, like the bird's beak shape that points to a muscle disorder, or the apple core shape that is a telltale sign of a tumor.
So the clues are in, the images are back, but before anyone makes a final call, there's one last absolutely critical step. The doctor has to run through this rapid mental checklist to rule out the things that could kill the patient in the next few hours. This is the do not miss list.
And this whole idea is built around the concept of the acute abdomen. Now, that's not a single disease. Think of it more like a red alert, a code red for the belly. It's a situation that screams, surgical emergency is highly likely, and the top priority becomes checking for the most immediate threats to life.
Number 1 on that checklist, is the patient in shock? Basically, is their circulatory system failing? A super low blood pressure and a racing heart are huge warning signs. Because before you can even think about what's causing the problem, you have to stabilize the patient. Nothing else matters if their body is in the middle of a systemic collapse.
Second on the list, is there a perforation? Has a hole literally opened up somewhere in the gut, spilling toxic stuff into the abdominal cavity? The classic sign is a belly that is as hard as a wooden plank. They call it board-like rigidity. That is a 5-alarm fire. It's a surgical emergency that means an immediate trip to the operating room. No passing go.
And third, ischemia. Now this one is really terrifying. It means the blood supply to the intestines might have been cut off and the tissue is starting to die. The most chilling sign here is pain out of proportion to the exam. The patient is in absolute agony, but when the doctor examines them, their belly feels surprisingly soft. It's a massive red flag for a dying bowel, and it's a condition that can be fatal in just a few hours if it's missed. So when you put it all together, from a simple question about swallowing liquids all the way to the feel of a patient's abdomen, what you see is this incredible masterpiece of deductive reasoning. It really drives home the point that for a good doctor, a symptom is never just a symptom. It's the first clue, it's the start of the story, and it's the beginning of a high-stakes investigation to find the truth hidden deep inside the human body.